Okay, we're live. So, I'm sure that we will have more viewers that start joining in. This link is live to our numerous social media sources. So, we'll go ahead and get started since we do have quite a few questions to get to.
Okay, Kimberly.
Welcome to Dysautonomia Support Network's Ask the Expert series. I'm Kim Hartman, DSN's Medical Clinical Liaison Coordinator, and also one of our advocacy team co-leaders. Tonight we will be focusing on gastroparesis and are joined by Dr. Richard McCallum, a native of Brisbane, Australia. Among the facilities that he has worked at include UCLA, Yale New Haven Veterans Administrative Hospital. He also has worked at University of Virginia, Kansas University Medical Center, where he also was the director of the Center for GI, Nerve and Muscle Function and GI Motility. He currently is the founding chair of medicine and has built a nationally competitive Department of Medicine at Texas Tech University Health Sciences Center in El Paso, Texas, as well as advancing research funding and starting fellowship programs. Dr. McCallum has published more than 390 articles in peer-reviewed scientific journals, 100 textbook chapters, and has edited 13 scientific textbooks. He serves on the editorial boards of 8 scientific publications and committees of the major gastroenterology associations in this country. He has made major advances in diagnosis and treatment of gastroparesis, especially in diabetes. For the last 20 years, his pioneering efforts in the area of electrophysiology of the gut and specifically electrical pacing of the stomach resulted in new therapeutic concepts for nausea and vomiting. Other research contributions that continue are in the recognition of cyclic vomiting as a major new etiology of nausea and vomiting in adults, diagnosing and treating dumping syndrome and rumination syndrome, as well as other gut motility problems such as anorectal motility disorders and irritable bowel and the spectrum of small bowel bacterial overgrowth. Developing new pharmacological and medical device therapies for these entities are also ongoing projects. Dr. McCallum, welcome and thank you for joining us tonight. We asked our DSN members what questions they had for our expert, and we will be asking you those questions so that we can truly serve our population. So I have quite a list of questions. We're going to try to keep this to an hour. So first off, kind of starting out with symptom questions for you.
Okay.
For those with regurgitation or reflux, as a result of their gastroparesis, do acid reducers make this symptom better or worse? What are the recommended treatments?
Well, thanks, Kimberly, for your introduction, number one, and for our questions from the audience that will come. Reflux, yes, we treat it as we do for your general patient who doesn't necessarily have gastroparesis. We use what's called proton pump inhibitors. But we know that with vomiting intermittently, we are recoating the esophagus with bile and acid as well. And this can be challenging. Many times with vomiting, a hernia may be induced over time, and you've got a combination of hiatal hernia and reflux. So sometimes these patients can exceed or not respond to proton pump inhibitors, elevating their bed at night, eating small amounts, and we have to resort to surgery. Now, that's in a small subset, but we've got a very interesting technique we use now called a partial fundoplication. Normally you wrap the stomach around the bottom of the esophagus. That's called a fundoplication. We created a partial wrap called a door, an anterior wrap of 270 degrees. And that allows you to belch and burp and vomit if necessary, and still try to minimize your reflux, but not close the gate totally. So we treat them aggressively with acid blocking drugs. And of course, we treat their gastroparesis by doing a pyloroplasty and a neurostimulator. So when you take away the gastroparesis, restore normal gastric emptying, often the reflux follows, it goes away. But we often, when we operate, do triple therapy: neurostimulator, pyloroplasty, and a 270-degree wrap to cover all the bases. And that's been very successful. Actually, we're just about to report that at a meeting soon. We've done about 10 in the last about 2 years. Patients are very happy. So that's the story in a nutshell. Can be challenging.
Sounds like it. I know I personally have had a toupee fund duplication and then also a Nissen fund duplication.
Yeah, toupee and door are interchangeable. Toupee is a posterior wrap. Door is more anterior. We prefer door because when you go posterior, you're getting close to the vagus nerve, and that may be not a good thing if we actually touch it or damage it. So we tend to stay anterior with the so-called door, but these are technical points.
Right. Okay. Here is one from another member.
Okay.
I've had issues with severe constipation for my entire life.
Mm-hmm.
Have been dealing with POTS for 6 months. It was rapid onset. Now I have tested positive for small intestinal bacterial overgrowth.
Mm-hmm.
I've lost a dramatic and somewhat frightening amount of weight, which I cannot regain or stabilize despite eating well. I've never been tested for delayed gastric emptying. Is there a common thread with these diagnoses and symptoms?
That's a good question. Hypermobility syndrome, a cousin of Ehlers-Danlos syndrome, is often present in the background of POTS. POTS patients have a tendency towards either rapid or slow gastric emptying. It's a bit more 60-40 rapid, so-called dumping syndrome, about 40% slow, gastroparesis. So POTS opens up a whole spectrum of potential gastrointestinal problems, from more reflux to more gastroparesis, increased pain, abdominal pain. They're sensitive to distension and movement of intestinal contents. Constipation can be present. SIBO, or small intestinal bacterial overgrowth, I don't think it's a given, but possibly more likely if you're constipated, certainly. So it tends to be a challenge. So-called POTS syndrome itself, when you stand up and have low blood pressure or high pulse rates, can make your life complicated right there with controlling heart rate, that alone. But in general, yes, we have to be open to looking at different parts of the gut. It's kind of a textbook. A lot of things can happen. One organ may be dominant. It could be 2 or 3 problems.
Okay. Is it common to have severe abdominal pain after drinking something or eating?
No, it's not a given at all. I mean, that's a red light or red flag. Why are we having more pain? There's irritable bowel syndrome by definition. I eat and I develop abdominal cramping and pain. And then there's dumping syndrome, where you eat a meal, even fluids, and they run out quickly from the stomach into the intestine cramps, and you have severe pain. That's called dumping syndrome. So no, that's not normal. It would imply that you've got rapid emptying of the stomach, or you could have this gastrocolic reflex called irritable bowel syndrome. And so it would lead you to want to consult a gastroenterologist and get a few answers.
Absolutely. The bloating. How much is gastroparesis and how much is dysautonomia? How does the approach for the two sources differ?
Yeah, so with gastroparesis, we assume that the lesion extends beyond the pylorus. So the stomach doesn't empty, sure, that's gastroparesis. But diabetes, autonomic dysfunction, vagal nerve damage will go beyond the pylorus into the small bowel. So we believe a lot of bloating and gas is really small bowel, that the stomach distends and the food sits there and you feel full. But diffuse bloating and patients say my abdomen gets distended, they send me videos of their abdomen growing. That would imply to me the small bowel is being distended by gas from bacteria, and that this is part of the gastroparesis syndrome where you have to involve the small bowel. It doesn't stop at the pylorus.
Okay. What are some of the early symptoms that you should watch out for? I'm scared I might be developing. I've heard that it sometimes causes weight gain. Is that true, and why?
Including weight gain as well, you're saying? Well, weight gain is a variable. The most sensitive symptom is I feel prematurely full when I eat. We call it early satiety. I can't finish a meal which I could finish last year. I get prematurely full. I can't finish my meal at the restaurant. Everyone else is eating well and I'm finished. I have to stop prematurely. They're the two commonest, maybe some postprandial nausea. You don't have to vomit. Vomiting comes later. Many people stay under the radar and don't vomit. They learn to stop or eat small volumes. Weight gain is a variable. We often see people who may be overweight when it starts, and they're not preserved or protected from gastroparesis. They could get viral gastroenteritis, they can get vagotomies, they can get diabetes. Gaining weight may be a little bit concerning, whether you've got simultaneous hypothyroidism, we want to check that, or whether you're just getting around it by drinking a lot of fatty calories just to keep something down, milkshakes, drinks that contain calories just to maintain hydration. You could trick the gut and maybe maintain or gain some weight that way, but over time, weight gain probably does not continue.
Okay. Let's see. Why are the symptoms of gastroparesis more constant for some people and more cyclical for others?
Yes, that can be a tough one to sell. We preach the gospel that it's like having a stroke. Your stomach is not working on day one. It doesn't miraculously recover tomorrow and you can eat a big meal. So we do press very hard, I do, to make you admit to me that every day you have degrees of nausea, fullness, pressure. You may not vomit, but every day is sort of a bad day. We like to separate that from someone who has dramatic attacks of pain and vomiting, admitted to the ER, admitted to the hospital 4 or 5 days, vomiting 20 times a day, dry retching, but then comes home and feels wonderful for a month or so, eats everything. We want to distinguish those two entities. One is called cyclic vomiting syndrome, and one is called continual hardcore gastroparesis. They can overlap. Some diabetics in particular, when they get out of control and go into ketoacidosis, will vomit dramatically for 4 or 5 days on top of gastroparesis. But cyclic vomiting has its own sort of blueprint, and we generally want to separate the two. Marijuana, migraine, stress. It involves other concepts than just my stomach doesn't work. So yes, there are cycles in the diabetics, particularly bad glucose control, and maybe sometimes using narcotics for neuropathy, or maybe severe stress in life. But we do want to separate cyclic vomiting in general from gastroparesis. Totally different treatment, totally different prognosis.
Okay. Are prebiotics and probiotics helpful to combat gastroparesis? Are there other supplements that someone with gastroparesis should be taking?
My general concept is no. I don't think I'd hold out hope for those two things. I do use probiotics in patients who are on PPIs, proton pump inhibitors for acid reflux, and who get gas and bloating. And they can't stop the PPI because their reflux would be too bad. And so I give them often probiotics. I may give them vinegar, particularly vinegar and apple juice, vinegar and lime juice, vinegar and lemon juice, to appease their GI tract, to give them acid in their small bowel, because I can't stop the PPI right away and they've got no acid in their small bowel to kill bugs. But to treat the true gastroparesis, make my stomach resurrected, no, I don't see probiotics helping that particular pathology, but they can help the big picture of gas and bloating accompanying gastroparesis.
Okay. Here's another one. I have both Ehlers-Danlos syndrome and dysautonomia with gastroparesis. None of the prokinetics have worked, even IV administered. I'm currently using a PEG for jejunal feeds. My GI doctor believes putting in a gastric pacemaker is the only thing that may help. I'm just wondering if there's anything that has been found to be helpful in the specific Ehlers-Danlos dysautonomia population. No one seems particularly confident in that the procedure will work with Ehlers-Danlos, and they're worried about complications, but they're not offering alternatives either.
Well, it's not going to help POTS syndrome. That's another world. We can't predict what the cardiac heart rate will happen. But my role indication for the neurostimulator, which I always put in with the pyloroplasty, it's a 1-2 punch now. The big deal about gastroparesis is we've grown. 10, 15 years ago, it was the stomach only. It's not. The stomach leads to an organ called the pylorus. We've got to go through a channel to reach the small bowel. That channel is not cooperative in gastroparesis. It's not willing to be pliable and open and accept food. Even if the prokinetic pushes the food down the stomach, it's got to get through the gate, and the gate can be very resistant. So I look at neurostimulator to be combined with pyloroplasty. I do it in Ehlers-Danlos, provided I do have a very rigorous gastric emptying test. We don't do this just because I'm vomiting, doctor, and I'm nauseated. I want to see delayed gastric emptying using a 4-hour centrographic egg meal, which is the standard meal. And I want to see that more than 20% retention at 4 hours. So we can't just be operating to be busy. That's where surgeons get into trouble. We've got to have a target, but the target that won't be helped is pain. So if abdominal pain is part of the dysautonomia of POTS or Ehlers-Danlos, you'd have to hold your breath on pain. If you vomit less, pain should get less. You could hope. But some of the pain of dysautonomia is so-called visceral hypersensitivity. And sometimes just making the stomach empty again won't guarantee all my pain goes away, but I can guarantee nausea will go away largely, and you won't vomit. So you've got to pick your spots, how old you are, your quality of life, your expectation. It would make sense to do it, particularly because we don't have a great menu of prokinetics today. within 2 or 3 years, we're going to have a very significant increase in prokinetic drugs. But that's a long time if you're vomiting every day. So I think the gastric stimulator with the pyloroplasty can be done safely in pots. It's not a big operation. It's laparoscopic. It's not big league surgery. We're not burning any bridges. But the pain is a wild card. We'd have to think twice about how much pain you're expected to get to improve. It may not be more than 50% improved.
Okay. Next one. I have primary autonomic dysfunction and gastroparesis. At what stomach paralysis percentage is a tube/alternative nutrition source recommended? Is it solely on a case-by-case basis?
What's the indication for a tube in gastroparesis?
Correct.
Well, you're losing weight, for sure, despite every effort to drink liquids or caloric drinks, Ensure, Boost. You've tried every drug that you seem to be able to find. I love domperidone. Not all places can get hold of domperidone. Domperidone is called Motilium. It's available in Canada. It's available, I get it from New Zealand on a special FDA protocol. It's not illegal in this country. But I certainly would try it for myself before I'd give up on so-called prokinetics, which may be relevant to the last speaker, the last questionnaire as well, because the usual menu in this country is erythromycin, Reglan, and that's probably about it. And they're not hardcore enough. Reglan's got too many side effects. Erythromycin's unpredictable. So certainly you have to go to domperidone to exhaust your options. But after that, I used to be much more open going to a J tube. I don't use pegs. We go to a J tube because there's no point putting a peg through a stomach that's not working and trying to fill up the pylorus with a tube. I want my pylorus open, not filled up with a tube. And when I vomit enough, I'll vomit the tube back from the proximal jejunum into my stomach, typically midnight Saturday night. And we're in there together trying to put a tube back down my intestine at midnight. No one's happy. So we do a surgical jejunostomy. But I'm losing interest in that now because I do have a final solution. And I'm not going to torture people anymore. So if you fail antiemetics, can't take Reglan, you tried domperidone, and you're not getting anywhere, you're not working, you're in the ER once a month, I'm going to do a gastric stimulator with a pyloroplasty because I have a final solution. I saw a patient just today, diabetic and renal failure, 95% better with a normal gastric emptying. She can now get a renal transplant because she's not vomiting. She can take rejection meds. So I've taken away a lot of my jump through more hoops and hurdles, tough it out, suck it up. No, I don't think the J tube anymore can be justified. The only reason I put a J tube in would be in some patients who want to try to get off narcotics, because narcotics sabotage your gastric stimulator surgery. So if they say, gee, doctor, the pain therapist thinks he can taper me, give me 6 months, I might put a J tube in. If the situation is that I'm very psychologically clearly depressed and probably not functional enough to have surgery right now, we might buy some time with a J tube. But it's not a way of life. It's basically being on the Titanic with the life rafts are out, the ship is sinking. We're really buying time. And now I don't want to buy time. I want to give you salvation today and do the surgery and take away this torture. J tubes get clogged. They have some pain, infection around the J tube site. You don't like putting it under your dress. You're embarrassed. It's only a last resort, and we don't need it. We have a solution now. So I think J tubes are coming off the table, except in very special situations.
Okay. Moving on to some research. What is the latest in medical research? We've heard about the pyloric stent, but this person had heard about the pyloric stent, but was unsure if it was successful.
No, it's not. It moves around too much. It can't. Not like putting a stent in the esophagus when you have cancer, and cancer kind of grabs it and holds it, and you can eat and things go through it. In the pylorus, it's more mobile, it's more flexible, and eventually it is dislodged. And so it's a very temporary thing. You could do it for a couple of months if you've got some business issues or personal life issues where you can't devote 2 or 3 days to have a laparoscopic surgery, which is very simple. It's like Botox. The Botox doesn't work. We've given up on Botox. I think the stents are kind of, it's a gimmicky thing. It's not long-term. Now, the only long-term thing, cut the pylorus, called a pyloroplasty. In the future, there may be what's called endoscopic pyloromyotomies, where we do it endoscopically. But the big question right now is, do we need the stimulators? We're the only center in the world doing a double-blind study. So if you come to me right now, we're doing one tomorrow morning. I'm going to cut your pylorus and put in a gastric stimulator. But you and I are going to agree that you're going to give me 3 months. You're not going to know whether you turned on, and I'm not going to know whether you turned on. A secret person comes in one night at midnight and has the code and turns you on or off, and that's it. And at that point, we wait 3 months. And then at the end of 3 months, having assessed your symptoms, done a gastric emptying, we declare what the code is. If you're turned off, you have the option of being turned on. Generally, we turn everyone on, but at the end of the next year, we'll have 40 patients. And we will declare then, in a double-blind way, is pleuroplasty with a neurostimulator better than just pyloroplasty alone? And that will be a game changer. If you don't need a neurostimulator, then the door is literally open to anyone who wants to do endoscopic pyloromyotomies. You don't need surgery. So that could be a very pivotal point. In about 18 months, we'll know, do you need a stimulator as well to take care of nausea, in addition to making your stomach empty normally, as in pyloroplasty? Or do we just need the pyloroplasty alone? Your stomach empties normally. You can take care of the rest by just eating carefully. That's going to be a very pivotal point in the history of gastroparesis.
Sounds like some amazing stuff on the horizon.
Yeah. Interesting.
Another patient, I know there are studies about diabetes and gastroparesis, but is there a known connection between gastric dysmotility and blood glucose instability that is not diet related? For example, if a person with GI dysmotility consistently has lower than expected blood glucose levels, but not low enough to be diagnosed hypoglycemic.
Mm-hmm. Now, that makes me think about dumping syndrome. So many people lump, I'm vomiting, doctor, or I've got nausea when I eat, I must be gastroparetic. I'm diabetic, or maybe not even diabetic, idiopathic. When you have dumping syndrome, you dump water and food out of your stomach at the rate of knots. Within 60 minutes, you've emptied 65 to 70% of your stomach's contents within an hour. Up goes your glucose at first. Insulin comes out to meet it, but then the food goes south down the small bowel and your glucose drops. And I have people at restaurants who, when they leave the restaurant, may faint in the car, may have a car accident coming home. And
because their sugars have crashed.
Their sugar has crashed. So that brings up the question of dumping syndrome. I usually don't see that in diabetics unless they take their insulin before the meal and they vomit. So many times we teach diabetics to wait till you've eaten for an hour. Is this meal going to stay down? Then take your insulin.
Right.
But in general, no diabetic, just unexplained hypoglycemia. you're dumping. And you often have diarrhea within an hour of eating. People rush to the bathroom at the restaurant before they go home because the food has run through you so quickly, it stimulates the sigmoid colon to have a bowel movement. Now, dumping is out there. We see it every day.
Okay.
And your treatment is to take glucose before the meal and with the meal. So, suck on hard candy, drink a glass of glucose, orange juice, or take some gummy bears or something. Get some glucose in you within 30 minutes to prepare for hypoglycemia.
Pre-medicate pre-crash.
Yes.
What autoimmune diseases can cause gastroparesis?
Endemic is scleroderma. I see this entity called connective tissue disease, scleroderma, every day, underestimated. I shake hands with a patient, she's got cold hands. First thing I think of is, yes, you could have Raynaud's only, but you could have Raynaud's plus a dry mouth, dry eyes, reflux, intermittent trouble swallowing. You've got the whole 9 yards. That means connective tissue disease, your ANA is positive, and 60% of people who have difficulty with scleroderma in their esophagus have delayed gastric emptying as well. So I think the most underdiagnosed entity I see, which is called idiopathic, it's not idiopathic. This patient has latent connective tissue disease, beginning in the hands, Sjogren's, dry mouth, dry eyes, reflux. They're red flags for connective tissue disease.
Can you still have gastroparesis with a normal gastric emptying test result?
No. I'm a black and white guy. I don't like touch of pregnancy. I don't like touch of pregnancy. We have to cut to the chase. So you come to me with a delayed gastric emptying or not. We're going to repeat it here because most centers are not doing it well. It's a 4-hour test using the two organic 2 egg beta meals, 2% fat, toast and a glass of water in an upright position. Picture every 30 minutes to 60 minutes for 4 hours. You could be normal, however, and have another entity called rapid fundic emptying. So when you first eat a meal, the food stays in the top of your stomach called the fundus for 30 minutes. Then it goes south into the antrum to be ground and mixed and triturated and moved through the pylorus into the small bowel. Some people's fundus does not relax, does not accommodate. You eat the food, the first course of the restaurant, boom, it goes straight to your antrum. The antrum's distended and stretched. You feel full, you feel satiated. That's it, doctor. I can't finish the meal. Everyone else is eating. I'm sitting here, can't eat the meal. But doctor, you told me my gastric emptying is normal. What's going on? You've got rapid fundic emptying, early satiety and fullness. By 4 hours, the antrum has squeezed and contracted and caught up. First hour or two, you feel terrible. It's not gastroparesis. It's rapid fundic emptying. We're now modifying our gastric emptying tests to measure the fundic component, taking pictures in the first 15 to 30 minutes to 1 hour, and we'll now read out. You have X% fundic emptying in 1 hour, should be more than 50%, or less than 50%. And you have gastric emptying at 4 hours. We're going to do more now. It's not just 4 hours, no. It's what's the distribution of the food? What's going on in that 4 hours? That's important.
Okay. What role does stress play in gastroparesis flares?
It augments everything. It definitely makes you more susceptible to complaining or having a lower threshold to not appreciate your nausea level and to maybe feel the pain is worse. But where stress is coming in and where it's being underestimated is in a condition called rumination syndrome. Okay, this is another player. It's now the commonest cause of vomiting in my practice. I see it every day, and I get phone calls every night about it. So this is a patient who eats a meal, drinks water, and within 5 to 15 minutes, it's coming up into her mouth, or his. It's more female. Comes up like a fountain. You have an option. Can I swallow quickly and bring it down, or do I turn to a trash can or a bag and vomit? That's within 5 to 15 minutes of eating. It's preceded by belching and burping. You belch and burp, before you know it, it's not air, it's fluid in my mouth. It's called rumination syndrome, not gastroparesis. Day and night, vomiting within 30 minutes, that's a red flag. And the commonest cause of that is in the preceding months before you started, you had a significant emotional event in your life, loss of a loved one, post-traumatic stress event, divorce, relocation, setbacks at work personally, family setbacks, maybe old trauma from your past catching up with you, cocktail of events. But the commonest cause of vomiting I see in my practice today is called rumination syndrome. And I get the call, Dr. McCallum, Mrs. Jones in the hospital, she can't stop vomiting. I can't get her out. She's vomiting water. She vomits every day, every meal. You got to put a pacemaker in. You got to put a J-tube in. You got to put TPN. She may be on TPN. Got to transfer tomorrow. That's a red flag. Vomiting every day, every minute, can't keep water down. That is rumination syndrome in all its glory. Not achalasia. The esophagus is open. We scoped it twice. There's no obstruction. Pylorus is open. Every time she eats, she brings it up. Dr. McCallum, what is it? It's rumination. It's like you were doing when your mother was feeding you and then patting you on your back, burping you on her shoulder with the towel. You brought milk back on the towel, burping as a 4-month-old baby. This is recapturing a primitive reflex, rumination. And the biggest tip-off is, doctor, my pain is unbearable. I've got this epigastric pain. They're giving me narcotics here in the hospital. What's going to happen to me? You are contracting your rectus muscle. This is your abdominal muscle that you're doing every day with push-ups. You're doing 100 push-ups a day, contracting your rectus muscle, causing pain. That pain's relieved by hot towels, lidocaine patches, and treatment for rumination, which is breathing and meditating and distraction. You've got to breathe, meditate, distract, and ignore the urge to belch and burp for 30 minutes and keep the fluid down. It takes a month to turn that ship around. Could take 2 months. Your stomach has been captured and entrained. You've got to reprogram it and bring it back to its old ways. Very, very, very significant challenge. I'm seeing it every day. I have my own tapes. I teach the patient to relax, to breathe, to meditate, to sort of go through this ritual of lying on the beach in a park, relaxing, rejecting the urge to belch and burp. Takes about 2 months. The biggest challenge is, doctor, I've lost weight already. I've stopped eating. I'm embarrassed. I don't eat in front of people. I try to hide it. I've lost 40 pounds. I'm so weak, I've got to go to the ER every week and get IV hydration. I can't even concentrate on your breathing. I'm too weak. Then I've got to put a J-tube in their intestine when I do use a J-tube for about 12 weeks. And I say, I'll give you a J-tube at night. I'll give you strength. You commit to breathing. We've got a deal. You've got 3 months. J-tube's coming out. It's not a way of life. It's a time for you to recapture your stomach. Very big entity going around the country. Misdiagnosed. I've had 3 patients in the last month who got gastric stimulators and come to me and said, doctor, nothing's different. I can't stop vomiting. One patient then went and got a gastric bypass. They took her stomach out, as in obesity. She comes to me and said, doctor, I'm still vomiting. No stomach, had a gastric stimulator, still vomiting. Did a barium swallow? Barium went straight through, no obstruction. Put her on my program. A month later, doctor, I'm no longer vomiting. Been vomiting for 3 years. So misdiagnosis of vomiting. Big problem in the country. Surgeons love to put in gastric stimulators. We'll take care of it. No. Every vomiting has its own unique niche. It's like a detective novel. You've got to gather the evidence. It's all different. Gastroparesis is there, so is rumination, so is cyclical vomiting, so is dumping syndrome, so is hypothyroidism, paraneoplastic syndrome, cancer chemotherapy, narcotics. You've got to drill down. That's the challenge for a motility doctor. It's not just bring them all on and we'll do a stimulator. Those days are gone. We learned the hard way. That is not the way to go.
Okay. If you have both gastroparesis and chronic constipation or irritable bowel syndrome, Crohn's, colitis, diverticulitis, how do you get regular without causing a gastroparesis flare? Also, are the two related or not?
No, I mean, irritable bowel is 20% of the world. Well, 40% of women. It's 15% of the world, but 80% of women. So if you add that up, it's 20% of women. So your high school class, if you have a reunion, you can have a cup of tea and talk about it, but 20% of your females have had irritable bowel syndrome, whether they know it or not. That can coexist with reflux, can coexist with gastroparesis. So no, we may still use certainly Linzess for constipation. We may use Vyburzi for diarrhea, abdominal IBS. Certainly we'll use, meditation, breathing, relaxation to try to help pain. No, I think irritable bowel can coexist. One of the biggest unifying parts of it is stress. Stress is omnipresent in irritable bowel. You can't have irritable bowel without stress. And stress will fire up your gastroparesis too. So many times I'm using a tricyclic at night. I may be using an SSRI at night. That's definitely in the picture when you have that combination. It may be in the picture alone, but just gastroparesis. You're so worn down, so overwhelmed by weeks, years of vomiting, you may need help psychologically to be stable. And I probably third of my patients to a half are on a tricyclic. I don't use SSRIs that much. I use a lot of tricyclics, particularly nortriptyline.
Okay. Why do one's safe foods change over time? Like one day safe foods? Like one day the specific food doesn't cause symptoms, but the next day the same food causes symptoms.
And this is in gastroparesis or just irritable bowel in general or what?
I believe this is in reference to gastroparesis.
No, that's a tough one. A tough one. I think we rule out sprue. We do go down through the list. I don't put people on low FODMAP diets just because they've got gastroparesis. I mean, I think that's overkill. We certainly try to minimize the fat and fiber, but sometimes any calorie is a good calorie. If you're struggling to maintain weight and just getting by, if you want to have a chocolate milkshake, I'm not going to really stand in your way. We may promote smoothies. Chilies and funny kind of hot sauces and things. Sure, I suppose they could be erratic depending on your mood level, perhaps. But no, I think irritable bowel, I see a lot more sort of unpredictability. Doctor, one day I can have this and I go to a restaurant and I can't have that. That's worrisome. Why does that happen to me? Some people talk about mast cell release, chocolates, almonds, serotonin releasing foods. You could argue that that's involved. I talk about scratching, itching, feeling red as in sort of mastocytosis type symptoms, but no, milk and soft drinks, the usual candidates we take out right away. But after that, I don't see I don't see that much chaos in gastroparesis. I see more chaos in irritable bowel. Maybe we're missing sprue. We double check the sprue test. Maybe it's sprue sensitivity. Sprue test is negative, but I'm sensitive, doctor. Sure, try a low gluten diet. We don't stand in their way to do that.
Okay. So with about 15 minutes left, I've got 4 questions left for you.
All right.
How is small fiber or autonomic neuropathy related to gastric motility?
Yeah, that's an evolving area. What we do know is that we focus a lot more on the interstitial cells of Cajal. These are the cells that make up the electrical rhythm of your stomach, the ICC. At the same time, we've done in diabetics particularly, in the idiopathics, we suspect there is an enteric nervous system problem. We see ganglia which have been infiltrated by mononucleocytes, inflammatory cells. There was an event, an incident, gastroenteritis, a trigger. We're trying to understand there what the series of events are that lead to impaired nitric oxide release, which in turn sets the stage for gastroparesis. So that's the future, really. I think at this point, we've got a cure. In my hands, we can always cure you. We can do a pyloroplasty and a neurostimulator. But we want to take a diabetic early. It's hard to take an idiopathic because we can't predict when they're going to get gastroenteritis or when they're going to get exposed to an insult. But when they have, do we use more aggressive autoimmune kind of treatment? Should we be giving Humira or some sort of inflammatory mediator inhibitor earlier? Should we be giving gamma globulin to try to augment defense in these patients? This is sort of the real future, I think, is early prevention. By the time they get to you with delayed emptying, vomiting, the cat sort of, the horses have left the barn. You're in severe catch-up mode. But I have seen idiopathics get better. In the Gastroparesis Consortium, we're following 400 people. And every year I see about 10 to 20% of my idiopathics mysteriously develop normal gastric emptying over time. So the stomach does heal from a viral injury. No question. A subset can heal. We don't do much except promote diet, give prokinetics, antiemetics, and time. But a subset, I think, have damaged nerve fibers enough they do not regenerate. And that's the future, I think, is, and one of the futures to do it is with what we're trying to do here and other places, is do non-surgical biopsies. So I could endoscope you tomorrow and get into your antrum, go below your submucosa and get some gastric smooth muscle. Go to the pathologist and say, what's my gastric smooth muscle look like early on? I'm just starting to vomit, it's just early. And then let's treat you with X or Y or follow you. I don't have to wait to go to surgery to get a biopsy and get smooth muscle. I can do another endoscopy in 6 months and see, is my smooth muscle getting better? Are my nerves getting better? Is the ICC getting better? So one of the problems is we've been restricted to surgical biopsies. That's 25% or 30% of the world is refractory and goes to surgery right now. And then we can take a divot out of your antrum while you're asleep. We need to look at the other 70% and find out what are the very early changes in that muscle. And that's being denied us right now until we get a non-surgical method of getting antral muscle. So we can give you an early reading of where do you stand, like a liver biopsy. Is your liver going towards cirrhosis? Is your liver stable? Are there any bad signs? We need to be able to biopsy that anytime we like.
Right. How does scar tissue play into gastroparesis, and how does one differentiate and manage both?
Well, I think the scar tissue only plays in when you've had surgeries for gallbladders, hysterectomies, and maybe miscellaneous laparotomies, endometriosis, whatever. And you've got fibers, you've got so-called adhesions left. And sometimes the adhesions grab the small bowel and it sort of mimics an obstruction or mimics gastroparesis. I start vomiting. That's obstruction. I don't think we believe scar tissue otherwise is playing much of a role in the standard gastroparetic stomach. I mean, we don't, if half your stomach was operated on for a peptic ulcer or some other indication, sure, then you've got an anastomosis and there may be scarring around the anastomosis, and that could play a role. But we're talking intact stomachs. The pylorus ends up getting scarred. When you biopsy it, it's fibrotic. So there is scar tissue there, but you didn't purposely make it happen. No one attacked your pylorus that you knew about, but it does degenerate over time. But I think it's mainly adhesions that have come from other things that might be blamed, like, gee, I'm vomiting again. Is it my gastroparesis, or am I obstructing my small bowel from adhesions? That can sometimes become a debate. And sometimes surgeons go in and say, gee, I'm going to cut your adhesions. We don't really promote that, because every time you operate, you leave a footprint and more adhesions follow.
More adhesions.
We really don't condone that.
Okay, last two. How does the vagus nerve come into play, and can the vagus nerve itself be treated?
Good question. So the vagus nerve today, its major way of getting into play is getting a fundoplication. There the surgeon is perilously close to your left esophageal vagus, which becomes the anterior stomach vagus, crosses over below the diaphragm. Could be coagulation, could be retraction, could be entrapment, could be occasionally, frankly, accidentally cutting it. But the main way to get gastroparesis today is from a surgeon accidentally, and in good surgeon. 1% of the time he's going to damage your vagus nerve. So if he does 100 fundos, 1 out of 100 people will wake up with degrees of bloating and nausea and what's called gastroparesis. What happens in those patients? We'd like to believe that maybe branches of the fundus grow back and reanastomose and reactivate and sort of overcome the loss. I'm not sure we see that. Some of my worst patients are post-vagotomy patients. They get B-sores in the stomach. The pylorus does not open. Some of the most receptive people to pyloroplasty are post-vagotomy, because that's why the surgeons in the old days, with your peptic ulcer, you'd have a pyloroplasty and a vagotomy. Every surgeon was taught, do a V&P, vagotomy, pyloroplasty. Reduce acid with a vagotomy, open the pylorus with a pyloroplasty. That's in the Bible of GI surgery. So we know if you do a vagotomy accidentally, my pylorus shuts down. So no, we don't have any sort of pyloric transplant, vagal nerve transplants. We think it could by time reanastomose somehow, but we wouldn't want to hold our breath. So although infrequent, I get a trickle, once every month or so. In comes, gee, doctor, what happened? Well, let's go back on your history. Ever had any surgery? Yeah, I had a fundoplication about 5 years ago. When did your nausea and bloating and fullness start? Well, about 6 months, 3 months after that. Are you blaming the surgeon? No, I'm not blaming the surgeon, but it's just life. And we don't sue surgeons. It's life. They're not bad guys. But this is just, if I do enough of them, if I drive home every night, one day I'm going to run a stoplight. That's life. It's not bad, but that's what happens.
And last question for you, also along the lines of vagal nerves. What potential effect would a vagal nerve stimulator for barrel reflex failure have on the overall vagal tone throughout the body? Would this impact the GI tract as well?
Yeah, so we have the people that are doing vagal nerve stimulation in the neck. I know you can get that for migraine and also do it for epilepsy. And I think it's been touted for the stomach. That hasn't gone anywhere. We've got some people putting stimulators on the lower esophageal sphincter for reflux, sort of on hold. The Mayo Clinic came up with a device which went nowhere to try to prevent obesity, that if I stimulate the vagus nerve, maybe I could block gastric emptying. That's not really been touted anywhere, sort of on hold. Yeah, the vagal nerve stimulation world has been full of twists and turns and hopes and promises. I'd say at this point, we're not going anywhere with vagal nerve stimulation. Maybe one day we'll figure out the right parameters, the right branch, but I'd say as of today, we wouldn't be able to say something in the next 3 years.
Okay. Well, I think that does it. I want to thank you for joining us tonight and being our inaugural guest for our Ask the Expert series. I know our members thank you, and I thank you as well.
Well, thank you, Kimberly. You did a great job. Let me say to the audience, Kimberly, you did a great job contacting me and setting all this up. It's a pleasure to try to reach out to people in need and try to educate and hopefully clarify. Medicine's a mysterious thing. Terms are used very sort of loosely. I hope I tried to focus a bit and give you some ideas.
You did an excellent job. Thanks, Dr. McCallum.
My pleasure. Good night.
Good night.